Hello, this is Dr. Lori Gardner, and this is Pregnancy and Mental Health for Nursing 591 691 at Nicholls State University. And let's get started. The objectives for this lecture will be to identify common psychiatric syndromes during pregnancy, evaluate the risks and benefits of psychotropic medication use during pregnancy, apply safe and evidence-based treatment strategies for managing psychiatric disorders in pregnant individuals, understand perinatal mental health screening and referral protocols. We will also discuss some postpartum care and psychiatric disorders. Mental health during pregnancy is often underdiagnosed and undertreated. Yet it can have profound impacts on both maternal and fetal outcomes. Psychiatric mental health nurse practitioners play a key role in screening, managing, and coordinating care for pregnant individuals with psychiatric disorders. Anxiety and depressive disorders are the most prominent disorders in females during the reproductive years. Mood and anxiety disorders are common during pregnancy. Women should be screened during the perinatal period. Women should be screened during their perinatal period. The American College of Obstetricians and Gynecologists, which is ACOG, and that is how they will be referred to throughout the rest of this lecture, recommend that women be screened for symptoms of depression at least once during the prenatal and postnatal periods. Anxiety and depressive disorders are the most prominent disorders in females during their reproductive years. Mood and anxiety disorders are common during pregnancy and the postpartum period, yet they remain underdiagnosed and undertreated. The perinatal period is an optimal time for providers to screen for perinatal psychiatric syndromes because of the frequency of contact. Also, the Women's Preventive Services Initiative, or WPSI, a program managed by ACOG along with the U.S. Department of Health and Human Services, recommends universal screening for anxiety in all adolescent and adult women ages 13 and older. This recommendation includes women who are pregnant or postpartum. Inconsistencies in defining the perinatal period make it difficult to determine prevalence and diagnosis. The DSM-5 manual includes onset of symptoms during pregnancy or within the first 4 weeks postpartum. However, the International Classification of Diseases 10th edition, or the ICD-10, identifies the postpartum period within 6 weeks of delivery, and the World Health Organization, or WHO, defines the postpartum period up to 1 year after delivery. Women may present with different symptom profiles and receive the same diagnosis. The timing of onset of symptoms may also contribute to differences in presentation. In the past, pregnancy was thought to be protective against mental illness, but more current research has proved otherwise. The perinatal period requires many physiological, psychological, and social adaptations, and therefore can serve as a trigger for the onset of first occurrence of psychiatric illness. Reproductive hormones play a role in emotional processing, cognition, and arousal, and can impact maternal biological and stress symptoms. Many psychiatric disorders have been linked to the hypothalamic pituitary adrenal, or HPA axis dysfunction, influenced by genetic, epigenetic, inflammatory, and microbial mechanisms. The emotional status of the mother influences the intrauterine environment, impacts the fetus, and can alter the trajectory of neurobehavioral and developmental. Untreated psychiatric illness during the perinatal period increases the risk of adverse maternal and child outcomes, such as spontaneous abortion, preterm labor, low birth weight, preeclampsia, and deficits in maternal-infant bonding. Children may exhibit poor cognitive, psychological, social, and emotional skills through adolescence. Also, women with untreated psychiatric illness are less likely to receive adequate prenatal care and are more likely to have poor nutrition and use tobacco, alcohol, and illicit substances. The stigma associated with mental illness is exacerbated during the perinatal period. Women with mental illness can experience significant shame associated with the decisions they face during pregnancy, especially regarding the use of medication. The psychiatric mental health advanced practice nurse is in a unique position to identify pregnancy-related mood disorders, minimize poor health outcomes for the mother and the child, and maximize the quality of the pregnancy experience. So let's begin with assessment. In your assessment of your psychiatric patient, you need to get a good prenatal history in the mother's pregnancy and delivery. So you want to know if this patient has been pregnant before, how many times, how many live births, any stillborns, any miscarriages, any spontaneous abortions, any elective abortions. How did she deliver? Was it vaginal? Was it cesarean section? And did she have any complications? Also, if known, their mother's pregnancy and delivery. Were they born full term? Were there any complications? Were they born by vaginal delivery or C-section? Did they have a nuchal cord around their neck? You want to get a very good assessment of the patient's prenatal history and their mother's pregnancy and delivery. Length of pregnancy, spontaneity, a normal delivery, any birth trauma, whether the patient was planned and wanted, and were there any birth defects. Any known history of prenatal or birthing problems or issues with developmental milestones should be noted. In women, a reproductive and menstrual history is essential, as well as careful assessment of the potential for current or future pregnancy. You may ask questions like, how do you know you're not pregnant? And they may say, because my tubes are tied, or because I've had a hysterectomy, or I just hope I'm not. So if they are not certain, if they have not had a hysterectomy or their tubes tied, and they are of childbearing age, you do want to get a urine pregnancy test before prescribing medications. Attitudes towards pregnancy and having children should be explored, any contraceptive practices and their feelings about them. I often ask their last menstrual period, if they're using any contraceptives, if they are, what type, have they been effective, if they're on medications, are they using more than one type, do they want to be pregnant, are they practicing safe sex not to be pregnant, how would they feel if they were pregnant? Some complications of pregnancy: toxemia. Toxemia, pregnancy, and uncontrolled maternal diabetes present hazards to the fetus and can potentially result in intellectual disability. Maternal malnutrition during pregnancy often results in prematurity and other obstetrical complications. Vaginal hemorrhage, placenta previa, premature separation of the placenta, and prolapse of the cord can damage the fetal brain by causing anoxia. Now, why would we worry about diabetes in pregnancy? You're probably thinking, well, we're not going to take care of her But some of our medications can lead to diabetes, correct? So this is something we need to make note of. Diabetes in pregnancy, particularly gestational diabetes, involves high blood sugar levels developing during pregnancy. This can affect both the mother and the baby, potentially leading to complications like high blood pressure, large birth weight babies, and difficulty with labor. While lifestyle changes and medications can help manage the condition, it's crucial for women to be aware of the risks and get proper care. So, the impact of psychiatric syndromes, we will discuss major depressive disorder, stress and anxiety disorders, bipolar disorder, post-traumatic stress disorder, obsessive compulsive disorder, and schizophrenia spectrum disorders. About 15 to 20% of pregnant individuals experience some type of perinatal mental illness. Untreated maternal psychiatric illness is linked to preterm birth, low birth weight, developmental delays, and impaired mother-infant bonding. So let's talk about major depressive disorder. High rates of relapse of major depressive disorder during pregnancy for women who discontinue, attempt to discontinue, or modify their medication regimens. Women should continue medications during pregnancy and postpartum. We always want to weigh the risks versus the benefits with the medications. The impact on infant development is unknown. And no significant risk of major congenital malformation after SSRI exposure, except for paroxetine. There is no significantly increased risk for major congenital malformations after exposure to SSRIs during pregnancy, with the exception of paroxetine, which I will discuss in this lecture. So the risk of relapse into depression when a newly pregnant mother is taken off of SSRIs is several-fold higher than the risk to the fetus of exposure to the SSRIs. There is some evidence suggesting increased rates of special care nursery admissions after delivery for children of mothers taking SSRIs. There is also a potential for a discontinuation syndrome with paroxetine. However, there is an absence of clinically significant neonatal complications associated with SSRI use. Studies that have followed children into their early school years have failed to find any perinatal complications, congenital fetal anomalies, decrease in global intelligence quotient or their IQ, language delays, or special behavioral problems attributable to the use of fluoxetine during pregnancy. Babies whose mothers are taking an SSRI in the latter part of pregnancy may be at slight risk of developing pulmonary hypertension. Data on the risk of this side effect are inconclusive, but it is estimated to involve 1 to 2 babies per 1,000 births. Again, paroxetine should be avoided during pregnancy, and I will discuss paroxetine later in this lecture. So this picture just shows some of the issues that we can see with untreated depression, like inadequate maternal weight gain, substance use, poor maternal care, self-care, preeclampsia, fetal distress, postpartum depression, impaired fetal placental function. And then with antidepressants, we may see cardiac defects, persistent pulmonary hypertension, major malformations, postnatal adaptation syndrome. And then we see that the overlapping of these can also cause miscarriage, preterm births, low birth weight, small for gestational age or SGA, and long-term neurodevelopmental anomalies. Serotonin also plays a role in vasoconstriction with a possible association with persistent pulmonary hypertension. Persistent pulmonary hypertension of the newborn, or PPHN, is a condition that can result in compromised oxygenation and can lead to respiratory failures. Factors such as obesity, prematurity, cesarean section, and smoking can also contribute to persistent pulmonary hypertension. PPHN was first associated with SSRI use in pregnancy in 2006. The FDA issued a public health advisory stating that PPHN was 6 times more common with fetal exposure to SSRIs after week 20 of pregnancy. Subsequent studies have produced conflicting results regarding SSRIs, SNRIs, and TCAs, and other antidepressants and the risks of PPHN. In 2011, the FDA stated that the healthcare professionals should not alter their practice due to inconclusive evidence regarding SSRIs used during pregnancy and PPHN. So, what are they telling you? Weigh the risks versus the benefits. There is evidence suggesting a relationship between the use of serotonergic agents in bleeding disorders and pregnant women using serotonergic medication having an elevated risk of postpartum hemorrhage when taken near the time of delivery. Some studies found that pregnant women using serotonergic medication have an increased risk of primary pulmonary hypertension, but the risk was also high in women using other psychopharmacological medication. Referencing alternative variables may confound the data. A systemic review and meta-analysis noted an increased risk of postpartum hemorrhage for women taking serotonergic and non-serotonergic agents. Despite this concern, there is no compelling evidence to require changes in antidepressant prescribing practices, but obstetricians should be aware of the possible risks to reduce maternal morbidity. Sertraline is often recommended as a first-line SSRI to consider in the management of perinatal depression due to its safety profile. Sertraline has the lowest ratio of umbilical cord serum to maternal serum concentration in a large database suggesting breastfeeding compatibility. Sertraline is well tolerated and has a wide therapeutic dose range. Escitalopram is recommended as an alternative for women that cannot take sertraline. Paroxetine is considered safe in breastfeeding, but fluoxetine and citalopram should be avoided due to accumulation effects. The authors noted that if a woman is stable on these agents during pregnancy, they may be continued without monitoring. Okay, let's talk about stress and anxiety. We'll discuss the neurobiology, how females, of course, are more than 2 times more likely to have experienced stress and anxiety than males. We'll discuss panic disorder and the prevalence of pregnant and postpartum women that are affected. We'll also go over some of the risk factors. Acute and chronic maternal stress that can impact fetal development is stress and anxiety, right? One of the most studied biological mechanisms to explain the relationship between maternal stress and infant outcomes is the HPA axis. I just discussed the HPA axis in another slide, so it's probably important to know. Exposure to stress activates the HPA axis, which in turn results in the release of several hormones, including cortisol. Cortisol levels steadily rise during pregnancy and peak in the 3rd trimester. I'll say that again. Cortisol levels steadily rise during pregnancy and peak in the third trimester. Cortisol levels are inversely related to dopamine and serotonin levels, which play roles in the motivation reward system and regulation of mood, sleep, and appetite. The placenta also produces corticotropin-releasing hormone, or CRH, that stimulates the fetal HPA axis and subsequent stress regulation by the infant. The amount of cortisol that crosses the placenta is regulated by the enzyme 11-beta-hydroxysteroid dehydrogenase type 2, or 11-BHSD2. Elevated cortisol levels lead to downregulation of 11-BHSD2. Excessive fetal exposure to cortisol impacts fetal growth, the developing nervous system, and may have long-term implications regarding emotional and cognitive development in infants and children. The sympathetic adrenomedullary, or SAM system, also regulates the stress response and influences fetal programming. Catecholamines cause constriction of placental blood vessels that ultimately reduces fetal nutrient and oxygen supply and downregulation of 11-BHSD2. These actions indirectly influence fetal growth and subsequent action of the HPA axis. Additionally, chronic stress can lead to immunosuppression, disrupted maternal sleep patterns, poor nutritional intake, and increased use of alcohol and illicit substances that contribute to the physiological changes in the fetal environment. The strongest predictors for peripartum mood disorder are anxiety and depressive disorders existing prior to pregnancy. Peripartum anxiety is associated with lower self-esteem and self-efficacy, reduced social support, and lower partnership satisfaction. Elevated stress and anxiety in pregnancy correspond with lower socioeconomic status and educational level, fears and concerns about delivery, young maternal age, history of trauma, and premenstrual syndrome prior to pregnancy. Perinatal anxiety disorders are associated with preterm birth, low birth weight, hypertensive disease of pregnancy, preeclampsia, and difficult labor and delivery. Anxiety can exacerbate physical symptoms associated with pregnancy, such as hyperemesis gravidarum, headache, and palpitations. Oh, I do want to go back. So, panic disorder, the median age of diagnosis is between 20 and 24. 21% of pregnant and postpartum women are affected by stress and anxiety, and I did discuss the risk factors. Postpartum stress disorder. Perinatal post-traumatic stress disorder, or PTSD, has been defined as a disorder that develops after a traumatic experience from conception to 6 months postpartum. Symptoms must be present for at least 1 month and lead to specific negative symptoms and poor maternal-infant outcomes. The DSM-5 does not identify childbirth as a traumatic event and does not have a specifier for PTSD. Perinatal PTSD appears to increase between 1 and 6 months and may be due to the emergence of a new disorder or exacerbation of a previous diagnosis. Perinatal PTSD can lead to high-risk behaviors such as smoking, drug and alcohol abuse, and is associated with poor prenatal care and pregnancy complications such as preterm birth and low birth weight. Medical trauma, including spontaneous abortion, elective abortion, or other forms of perinatal loss, is a strong predictor for the development of PTSD. Childbirth-related PTSD is affiliated with first delivery, low educational level, fear of childbirth, expectations of pain, lack of social support, cesarean section, an instrumental birth, and overall negative subjective birth experience. So what would be an instrumental birth? Maybe someone who is having a forceps delivery or a vacuum extraction. So a vacuum extraction is where they put a little cup on the baby's head to help the baby either come down the birth canal, or if it's a large baby born via cesarean section, they may still use that cup to help get the baby out of the uterus. So that's an instrumental birth. Research suggests that women with PTSD may receive inadequate prenatal care due to avoidance of intrusive medical procedures that act as triggers. So can you imagine someone having a instrumental birth? And maybe back in the day when they used the metal forceps, I'm not sure if they still use those because I have not been in a delivery in a while. But when they have to use those metal forceps to pull the baby down, or the vacuum, and then the female gets an episiotomy, and it's really traumatic, or maybe she labors for hours on end, and she gets an epidural, and the epidural doesn't work, and it's really traumatic for her, she may avoid having prenatal care on the next pregnancy. Bodily changes during pregnancy and delivery can trigger memories of past trauma that may lead to disassociation or depersonalization. Physical sensations during vaginal birth and interventions, such as checking dilation status, may be very anxiety-provoking for patients with a history of sexual trauma. So what does that mean? A female who was exposed to maybe being molested when she was younger by a male figure in her life, and then when she's laboring, she has to have her cervix checked quite often to see how the labor is progressing, and that may trigger some very negative feelings. Adverse consequences of PTSD in the postpartum period include higher rates of comorbid depression, impaired maternal-infant bonding, difficulties with breastfeeding, abstaining from sex, and overall poor coping. So we'll move on to bipolar disorder. Episodes occur during pregnancy or within 4 weeks after delivery. With peripartum onset, mania occurring after pregnancy is a critical issue given the potential risk to the child, and we will go into more detail about this. It's associated with adverse perinatal outcomes such as prematurity, low birth weight, antenatal hemorrhage, placenta previa, and preeclampsia. Women with bipolar disorder can experience significant functional impairment in pregnancy and during the postpartum period. Bipolar disorder is associated with adverse perinatal outcomes such as prematurity, low birth weight, antenatal hemorrhage, placenta previa, and preeclampsia. Women with bipolar disorder have a 50% increased risk for recurrent episodes throughout the perinatal period. Depressive episodes appear to be more common during pregnancy, but can include mixed states. Women with bipolar disorder are more likely to discontinue mood stabilizers in the first trimester of pregnancy, and discontinuation of medication is correlated with a higher rate of relapse. Untreated and uncontrolled symptoms of bipolar disorder can lead to impulsive and high-risk behaviors that contribute to poor maternal self-care, lack of adherence to prenatal care regimens, disruptions in social support, and substance abuse. Mood stabilizers and antipsychotics are most often used to treat bipolar illness, and both classes of medication carry risks. Lithium, which you will hear me discuss several times throughout this lecture, has the largest evidence base for efficacy in the perinatal period compared with other mood stabilizers, and thus far has not been correlated with significant adverse childhood neurodevelopmental outcomes. However, the use of lithium during pregnancy is not without risk. Fetal exposure to lithium has been associated with congenital cardiac defects, most notably Epstein anomaly, a malformation of the tricuspid valve with ventricular hypoplasia. It's very important that you know what medications are teratogenic, did I say that right? Cause fetal harm. You will need to know which medications cause what anomalies. So I'll say it again. Lithium is associated with congenital cardiac defects, most notably Epstein anomaly, which is a malformation of the tricuspid valve with ventricular hypoplasia. Obsessive compulsive disorder. Pregnancy can precipitate the onset or worsen symptoms of obsessive compulsive disorder. Symptoms of OCD are considered stress responsive, and many women report a worsening of obsessive compulsive symptoms postpartum. Poor sleep, fatigue, and a family history of OCD increase the likelihood of developing this disorder in the perinatal period. Treatment includes CBT, sertraline, citalopram, and escitalopram. The etiology of perinatal OCD and OCS is likely multifaceted with biological and psychosocial contributions. Biological theories report that there's alterations in serotonin, estrogen, progesterone, and oxytocin as contributing factors. Now, if I'm mentioning this, it's probably worth knowing that biological theories report alterations in serotonin, estrogen, progesterone, and oxytocin as contributing factors. Fluctuations in perinatal estrogen and progesterone may influence serotonin binding and reuptake. Oxytocin, which functions as a neurotransmitter, increases during late pregnancy and is thought to play a role in the development of postpartum OCD. Women with OCD may also be more reactive to stress and anxiety due to elevated cortisol levels. The impact of perinatal OCD can be significant. Studies have found that maternal OCD has a negative impact on gestational length and fetal growth. Obsessive thoughts and compulsive behaviors are distracting and disruptive, potentially contributing to functional impairment and lower maternal self-efficacy. Postpartum OCD can cause pronounced distress and impact the entire family system by reducing maternal-infant bonding, marital satisfaction, rates of breastfeeding, and overall ability of the mother to care for herself and her baby. Onset of OCD or OCS can be acute or gradual. It has been reported that postpartum onset of OCD symptoms tend to occur rapidly and usually in the first 4 weeks. The content of perinatal obsessions and compulsions are usually specific and stable with several recurring themes. Contamination obsessions and the need for excessive washing or cleaning behaviors are common. This may result in avoidance of activities and contact with others due to fear of infection. Images and thoughts of the newborn dying may lead to frequent checking, especially while the infant sleeps. Prevalence rates of passive and active harming thoughts are high, particularly in the first few weeks postpartum. Harming intrusions, like other obsessional thoughts, are often triggered by stressful cues, such as infant restlessness and crying. Mothers with coexisting OCD and depression tend to have more aggressive obsessions, including thoughts of harming their babies. Women with OCD are at a low risk for acting on harming thoughts because these intrusions are typically ego-dystonic. Many women with OCD are reluctant to disclose the content of their thoughts and subsequent behaviors due to shame, fear of being misunderstood, and worry concerning the involvement of child welfare services. Additional sources of information provided by a partner or close family member can be invaluable. There is a perinatal obsessive compulsive scale, or POCS. It's a self-report questionnaire to detect obsessions and compulsions during pregnancy. Both prenatal and postnatal versions of the POCS are available. The Yale-Brown Obsessive Compulsive, or YBOCS scale, is another tool that can be used to detect and determine the severity of OCS. Severe cases of OCD can be mistaken for postpartum psychosis, so it's important to differentiate between these two syndromes and to rule out the comorbid conditions. Women with OCD typically have insight into their obsessions and the irrational nature of their thoughts. Postpartum psychosis is characterized by hallucinations, delusions, and thought disorganization that limits maternal understanding of symptoms. Any obsession with content of possible harm to the fetus or infant requires a detailed assessment and immediate measures to promote the safety and well-being of both mother and baby. Treatment includes similar approaches effective for the management of OCD in the non-pregnant population, including CBT, response prevention, and psychotropic medication. CBT alone may be adequate in treating mild to moderate symptoms or used in conjunction with pharmacotherapy for more severe cases. Pharmacological treatment should be considered for women with severe anxiety and depressive symptoms, high suicide risk, significant feeding and sleep disturbances, or symptoms that are not responsive to psychotherapy. Schizophrenia. Historically, women with schizophrenia had lower fertility rates, presumably a consequence of prolactin-raising first-generation antipsychotic medications. Fertility rates are higher now due to the increased use of second-generation antipsychotics with a lower propensity to cause hyperprolactemia. The number of unplanned pregnancies in women with severe mental illness ranges from 50 to 70%. Chronically ill women may develop a psychotic denial of pregnancy that can impact adherence to prenatal care or failure to recognize labor. Pregnant women with schizophrenia experience more anxiety and depression and have a high rate of tobacco and substance use. Women with schizophrenia tend to have many coexisting health problems, such as diabetes, hypertension, obesity, and thromboembolic disease that can contribute to obstetric complications. The diagnosis of schizophrenia, like bipolar disorder, conferred a 5 times increased risk of preeclampsia that can lead to preterm labor and hypoxia-related neurological injury. Adverse neonatal outcomes include preterm birth, small for gestational age, large for gestational age infants, and low APGAR scores. The postpartum period is also a time of heightened vulnerability for women with schizophrenia. Approximately 1 in 5 women with schizophrenia required psychiatric hospitalization within 1 year postpartum. Psychiatric nurse practitioners are uniquely qualified to provide the education and tailor it to the health literacy of their patient. Other educational resources that may prove helpful include childbirth and parenting classes, assessing knowledge in relation to the contribution that comorbid illness such as diabetes and hypertension has on pregnancy is necessary, along with coordinating care with other medical professionals. Antipsychotic medications are often used to treat schizophrenia and are increasingly being used off-label to treat anxiety, depression, and insomnia. Relapse rates are high in women with schizophrenia that discontinue medication. Most evidence supports prescribing antipsychotic medication during pregnancy for women with severe illness and using the lowest dose to achieve benefit. Depot medication should not be initiated during pregnancy due to the lack of flexibility in dosing, but should be maintained if pregnancy used if it's producing symptom relief and stability. Abrupt discontinuation of antipsychotic medication is not recommended due to the potential of inducing withdrawal symptoms and/or acute psychosis. In general, use of antipsychotics should be guided by each drug's safety profile and the psychiatric history of the client. First-generation antipsychotics have been widely used and have a larger reproductive safety profile compared to second-generation antipsychotics. Chlorpromazine, haloperidol, and parafenazine have been studied the most, with no significant relationship between the use of medications and major congenital malformations. There is a recommending the use of high-potency first-generation antipsychotics over lower-potency agents to reduce anticholinergic, antihistaminic, and hypotensive effects. Although data is limited, a few studies suggested that the FGA's exposure was associated with increased risk of preterm birth and low birth weight. Infants exposed to first-generation antipsychotics, or FGAs, are characterized by restlessness, tremor, Parkinsonism, dystonia, hypertonicity, and feeding difficulties. Atypical agents have replaced typical agents as first-line treatment for psychotic disorders. And next we will talk about immunizations, the effects on prenatal and postnatal, and acquired and developmental factors. So, in the perinatal period, chromosomal studies may be indicated. Some evidence indicates that premature infants and infants with low birth weight are at a high risk for neurologic and subtle intellectual impairments that may not be apparent until their school years. Infants who sustain intracranial hemorrhages or show evidence of cerebral ischemia, are especially vulnerable to cognitive abnormalities. The degree of neurodevelopmental impairment generally correlates with the severity of the intracranial hemorrhage. Recent studies have documented that among children with low birth weight, which is usually less than 1 kilogram, 20% had significant disabilities, including cerebral palsy, intellectual disability, autism, and low intelligence with severe learning problems. Very premature children and those who had intrauterine growth retardation were at high risk for developing both social problems and academic difficulties. Socioeconomic deprivation can also affect the adaptive function of these vulnerable infants. Early intervention may improve their cognitive language and perceptual abilities. Chorionic villi sampling, or CVS, is a screening technique to determine fetal chromosomal abnormalities. It is done at 8 to 10 weeks of gestation, 6 weeks earlier than amniocentesis. The results are available in a short time, which can be hours or days, and if the result is abnormal, it's possible to decide to terminate the pregnancy within the first trimester. The procedure has a miscarriage risk between 2 and 5%. The risk in amniocentesis is lower. It's about 1 in 200. A non-invasive blood test called the Maternity T21 is a proprietary prenatal test that detects abnormalities of chromosomes 21, 18, 13, X, and Y. It is highly specific for Down syndrome, and there is a slight risk of miscarriage. Primary prevention. Primary prevention comprises actions taken to eliminate or reduce the conditions that lead to development of intellectual disability, as well as associated disorders. For example, screening babies for PKU and administering a low phenylalanine diet when PKU is present significantly alters the emergence of intellectual disability in those affected children. Additional primary prevention steps include education of the general public about strategies to prevent intellectual disabilities, such as abstinence from alcohol during pregnancy, contributing efforts of health professionals to ensure and upgrade public health policies, and legislation to provide optimal maternal and child health care. Family and genetic counseling help reduce the incidence of intellectual disability in a family with a history of genetic disorder. And you're probably wondering, why are we learning about this in this lecture? Because the effects of these tests may affect the mother and her mental health. The prenatal period there's essential prerequisites for the overall development of the fetus, including the mother's physical, psychological, and nutritional health during pregnancy. Many illnesses and conditions can affect fetal brain development, including uncontrolled diabetes, anemia, emphysema, hypertension, and long-term use of alcohol and narcotic substances. Maternal infections during pregnancy, especially viral infections, have been known to cause fetal damage and intellectual disability. The extent of fetal damage depends on several factors. These factors include the type and severity of viral infection and the gestational age of the fetus. Rubella. Rubella, or German measles, has replaced syphilis as the primary cause of congenital malformations and intellectual disability caused by maternal infection. The children of affected mothers may show severe abnormalities, including congenital heart disease, intellectual disability, cataracts, deafness, microcephaly, or microphthalmia. Timing is crucial because the extent and frequency of complications are inversely related to the duration of the pregnancy at the time of maternal infection. When mothers become infected in the first trimester of pregnancy, 10 to 15% of the children are affected. This incidence rises to almost 50% when the infection occurs in the first month of pregnancy. Undetected subclinical forms of maternal infection can complicate the situation. Immunization can prevent maternal rubella. Syphilis in pregnant women was once the leading cause of various neuropathologic changes in their offspring, including intellectual disability. Today, the incidence of syphilitic complications of pregnancy fluctuates with the incidence of syphilis in the general population. Some recent alarming statistics from several major cities in the United States indicate that there is still no room for complacency when it comes to syphilis. Toxoplasmosis. The mother can transmit toxoplasmosis to the fetus. It causes mild or severe intellectual disability, and in severe cases, hydrocephalus, seizures, microcephaly, and chorioretinitis. Okay. And we have, let's see, human immunodeficiency virus, or HIV. Cognitive impairments are well known to be associated with the transmission of HIV from mothers to their babies. HIV may have both direct and indirect influences on the developing brain. A subset of infants born infected with HIV may develop progressive encephalopathy, intellectual disabilities, and seizures within the first year of life. Fortunately, over the last 2 decades, there has been a dramatic decrease in perinatal HIV transmission due to a combination of antiviral agents provided to mothers during pregnancy and delivery. Obstetric interventions that reduce risk and administration of zidovudine, or ZDV, as prophylaxis for 6 weeks to newborns exposed to HIV. In the United States, the annual number of HIV infections through perinatal transmission had declined about 40% over the last 5 years. It is dramatically less than in the 1990s when the transmission was at its peak. In 2015, the rates were less than 1% in white and Hispanic Latino HIV-infected mothers. However, that rate is about 5 times greater in African American mothers with HIV. Vertical transmission of HIV from mother to child around the world, especially in Africa, is also considerable. Now, I do have a term I want you to know. It's called pseudocyesis. That is a false pregnancy with complete cessation of the menses. So women who are afraid of becoming pregnant or who have a wish to be pregnant may have delayed periods. Okay, and we will move on to substance use and addictive disorders. Women with alcohol-related disorders have a 35% risk of having a child with defects. Alcohol remains one of the most widely abused substances during pregnancy. Alcohol is a known teratogen, and fetal exposure is considered the leading cause of preventable intellectual disability. Fetal alcohol syndrome. Data indicates that women who are pregnant or are breastfeeding should not drink alcohol. Fetal alcohol syndrome is the leading cause of intellectual disability in the United States, and it occurs when women drink alcohol and expose fetuses to alcohol in utero. The alcohol inhibits intrauterine growth and postnatal development. Microcephaly, craniofacial malformations, and limb and heart defects are common in affected infants. Short adult stature and development of a range of adult maladaptive behavior are also associated with fetal alcohol syndrome. Fetal alcohol syndrome results from prenatal alcohol exposure and can lead to a wide range of problems in the newborn. According to the Centers for Disease Control and Prevention, fetal alcohol syndrome in the United States occur at a rate ranging from 0.2 to 1.5 per 1,000 live births. The entire syndrome occurs in up to 15% of babies born to women who regularly ingest large amounts of alcohol. Babies born to women who consume alcohol regularly during pregnancy have a high incidence of ADHD, learning disorders, and intellectual disability without facial dysmorphism. So whether you drink a lot or you drink a little bit, there is still the possibility of a complication for the baby. Illicit opioid use during pregnancy is associated with adverse effects for both the pregnant woman and the fetus, but is not associated with any specific teratogenic effects. However, there is a higher risk of infections, preeclampsia, miscarriage, premature rupture of membranes, and premature labor, as well as stillbirths, premature infants, and infants with low birth weight, and neonatal opioid withdrawal, also called neonatal abstinence syndrome. Infants who survive may be infected with HIV and other diseases as a result of maternal high-risk behavior and are at risk of sudden infant death syndrome, or SIDS. Most of the risk can be substantially reduced with methadone or buprenorphine maintenance treatment. Prenatal exposure to opioids such as heroin often results in infants who are small for their gestational age, with head circumference below the 10th percentile, and withdrawal symptoms that appear within the first 2 days of life. The withdrawal symptoms of infants include irritability, hypertonia, tremor, vomiting, a high-pitched cry, and an abnormal sleep pattern. Seizures are unusual, but the withdrawal symptom can be life-threatening to infants if it's untreated. Diazepam, phenobarbital, chlorpromazine, and paregoric have been used to treat neonatal opioid withdrawal. The long-term sequelae of prenatal opioid exposure are not fully known. The children's developmental milestones and intellectual functions may be within the normal range, but they have an increased risk for impulsivity and behavioral problems. Infants prenatally exposed to cocaine are at higher risk for low birth weight and premature delivery. In the early neonatal period, they may have transient neurologic and behavioral abnormalities, including abnormal results on EEG studies, tachycardia, poor feeding patterns, irritability, and excessive drowsiness. The physiologic and behavioral abnormalities are from cocaine intoxication, not withdrawal, as cocaine excretion may be up to a week after delivery. Despite a great deal of research, no one has conclusively demonstrated a significant health risk from routine caffeine use. Nonetheless, caffeine use is considered relatively contraindicated for various conditions, like generalized anxiety disorder, panic disorder, primary insomnia, gastroesophageal reflux, cardiovascular disease, particularly hypertension and hypercholesterol, pregnancy, and infertility. Some of these are controversial. For example, there may be a mild association between higher daily caffeine use in women and delayed conception and slightly lower birth weight. Studies, however, have not found such associations and effects. So when they are found, it's usually from a relatively high daily dose of caffeine, like the equivalent of 5 cups of brewed coffee a day. For women who are considering pregnancy, especially if there is some difficulty in conceiving, it may be useful to counsel them to stop consuming caffeine. Similarly, for a woman who becomes pregnant and has a moderate to high daily caffeine consumption, a discussion about decreasing her daily caffeine use may be warranted. Now, tobacco dependence. Tobacco smoke contains toxic compounds such as nicotine and carbon monoxide that easily crosses the placenta with subsequent higher levels in the fetus compared to those in maternal tissues. Nicotine and carbon monoxide inhibit placental functioning and restrict the amount of oxygen and nutrients available to the fetus, reduce fetal growth, and impact organ development. Women who stop smoking before pregnancy or during the first 3 to 4 months of pregnancy reduce their risk of having low birth weight infants compared to that of women who have never smoked. The health benefits of smoking cessation substantially exceeded any risk from the average 5-pound weight gain or an adverse psychological effects after quitting.